So now we go back to Dr. Devendra Maheshwari, who will be covering microhook trabeculotomy.
Hello. Is what? Yeah. So I think there's no financial disclosure. I think already had been seen the MIGS become a trend. I think it's a need of era. Right now, these are the various MIGS options available for the various MIGS are there. And you look at the trend toward the surgery worldwide. MIGS is trending, and really down the line 5 years, everyone will do the MIGS as a first choice of surgery. Whatever the MIGS you want to decide, depend upon the economic condition, patient, how much patient follow-up can come for your follow-up. There are various factors involved. What kind of MIGS do you want? So look for the device-based and TM-based MIGS. I think India, most of the MIGS prevalent is TM-based. I think because the cost is a big concern in country like India, where you see the cost, really whooping cost of iStent and KDB, while the GATT and Bang can do in a few dollars. So coming to the goniotomy is long history. Otto Warkan did in 1936. Then problem with the goniotomy, really the inability to lift the tubercular mesh wall, while in the newer goniotomies, elevate and excise tubercular mesh wall, assess the collector channel. So the multiple studies has shown goniotomy has either incise or strip definitely reduce the IOP. So what are the challenges in India? Why we did not become popular in India? Because the cost, one of the big concern. If we go the point wise, like the GATT really have the steep learning curve. It produces wonderful IOP control. We can get the IOP 10 and 12, but again, learning curve and high FEMA. Post of high FEMA, we can't avoid. Even whatever you do, it may be happen in some certain cases. KDB quite expensive. Per case, we can do the 1 or 2 cases by spending 45,000 rupees. iStent have good safety profile, but again, look for the cost is the problem. Bang really is good safety profile, easy, economic, but again, I feel it really is a novice surgeon's hand and needle is little some risky. Though I countered my previous Suren sir, and he told really is very easy, but really the needle in the eye when you don't have the any MIGS experience, have to think about it. So coming to the Tanito microhook, it is a very efficacious, easy to learn, economic, has a very good safety profile. Why? So what we do in Abington trabeculotomy, we clip the trabecular meshwork, inner wall of Sillins canal under direct visualization, thus reducing that outflow. Indication, like as usual, already all MIGS we have contraindication, ocular inflammation, neovascular glaucoma, aphakic glaucoma, and advanced glaucoma. And beauty of this procedure, apart from the GATT, this is the only procedure where we can incise or reach the trabecular meshwork 180 to 240 degree. So you can see, apart from the GATT. And this is the instrument, is simple Sinskey kind of instrument. So they have 3 kind of instrument coming. One is a straight, one is a right angle, third one is a left angle. So why it is good? Because you see the devices, what we have for MIGS, and see this microhook like a Sinskey hook. I think every surgeon familiar with Sinskey. So I think add information, learning curve, it's much easier than any other instrument, because we all do the cataract surgery, all use the Sinskey. So really, it's just like a Sinskey instrument I saw in my surgical video. So I get the opportunity to meet the inventor of microhook, that Masaki Tanito, and I'll see this video, how easy procedure it is this. I think already my previous speaker has seen how to visualize the angle. So just dog the lens with high viscoelastic, what you're using, a density viscoelastic. And this is the side port. No need to create additional incision also. Just what the side port you made for the phaco, throw the side port, take the hook, and just cleave the trabecular meshwork. And just one right hand side, then take the left hand side, go to the supranasal. Similar way, you can say the nice, beautiful, by the back wall of the Sillins canal. And similar way, you can turn to the opposite side and you can reach to the temporal angle. First nasal angle, then you go to the temporal angle. apart from that, the beauty of this procedure, certain situation you see like the complex situation where any incisional surgery is really, I think, difficult, whether trap or tube, really is you have to do multiple surgery, then you can do MIGS in such cases. And this is the procedure. Oh, sorry. Yeah. Sorry. So after finishing the phacoemulsification, though it's complex case, we have to use the CTR, hooks, everything. And after that, you can see this, again, you're going to the micro hook and you can incise the nasal angle. Just you do the 3 to 4 o'clock over into the both side and you can get the excellent IP control similar to the KDB or Bang or any other available procedure right now we are having. Though we are learning slowly, so some colleague in the China, they are doing a lot of angle closure cases with the Tanito hook. Even the Tanito hook is much safer than angle closure in compared to GAD, Bang, KDB, irrespective of any procedure you have right now for stopping or tripping the trabecular meshwork. Why? Because this instrument is not very sharp. It's a blunt end. So you can see after doing phacoemulsification, you can do the goniosynostosis, and this hook can also be used for the goniosynostosis as I use a curved, so it gives a very good view. And after doing the goniosynostosis, deepen the chamber. After deepening the chamber, again take the hook. So this again take the hook through the main boot or side port, whatever you are having, and just you have to cleave the slim trabecular meshwork. And you can do right hand side, left hand side, and really if you need extra IP control, you can go for the 220 to 240 degree also. So we did the one study, it's called first randomized control trial on the micro hook we published in Ophthalmology Glaucoma. In this study, we took the 144 patient divided into 2 groups. One group went for phaco with microlot, second is a phacoemulsification. You can see the good IP control throughout the 12-month of period, 26 to 12 mmHg at 1 year. When you compare the IP control between phaco group and lot group, you can see the marked difference into the phaco versus the lot group. So, just I take the 2 minutes more. So just compare the complications. There's no complications. The only high beam is complication like any other procedures. And look at the survival curve. You compare the both phaco versus microlot. You can say microlot have the good IP control throughout the 1 year. Now look at the various study has shown the microlot produce good IP control and there is a reduction of the anti-glaucoma medication. When this micro hook is compared with the other devices like KDB, there is no significant difference. Then coming to micro hook, when one eye is put the micro hook, one eye put the eye stent, and it shows the micro hook has a good IP reduction in compared to the micro hook. So this again the TAM-TRACK study where they compare the micro hook with the trabectome, and really the micro hook has no inferior to the trabectome. Really, there's some complication, hypema and IP spike is part and parcel of any MIGS surgery. So the micro hook Tanito is efficacious and safe procedure to mild inverted glaucoma. Is a viable MIGS addition to the glaucoma surgery, especially in low and middle socioeconomic country. Thank you for kind listening.
Thank you, Dr. Devendra, for talking to us about microhook trabeculotomy and